Good afternoon, everyone, and good morning to those of you on the West Coast. My name is Joshua Lapp, and I am the Director of Policy and Practice Management at the Society of Hospital Medicine. We want to thank you for taking the time out today to join us for this webinar around responding to COVID-19 for hospital medicine. It's my pleasure to introduce the speaker today, Dr. Ruby Sahoo, who is the Regional Performance Director at TeamHealth and the Chief of Staff at Grand Strand Medical Center. She's also an internal medicine hospitalist and faculty involved in the residency program at Grand Strand. Also joining Dr. Sahoo for the question and answer at the end of her presentation is Dr. Rohit Appal, who is the Chief Clinical Officer for Hospital Medicine at TeamHealth, and Dr. Jody Crane, who's the Chief Medical Officer of TeamHealth. So a few housekeeping notes before we get started, and I hand this over to Dr. Sahoo. First is that if you do have questions, SHM staff will be moderating questions, so please write your questions into the question box, and we'll try to get to as many questions as possible on this webinar. If, as seems likely, given everything that's happening today with the COVID-19 pandemic around the country, we'll have more questions than we have time for. SHM staff will be working with volunteer members to find other times for webinars and other resources in the coming days and weeks to make sure that we're addressing as many questions as possible that you have. So without further ado, I'm going to turn it over to Dr. Ruby Sahoo, who thank you so much. You've given generously of your time today to share your perspectives and expertise with us, so thank you.
Thanks for that introduction, Josh, and thanks everyone for joining. The purpose of my talk today is to, number one, bring about awareness of COVID-19. There's just a ton of information out there, and we're all getting kind of bombarded with information from all angles. And so I felt it was very important to give very specific information relevant to hospital medicine to our clinicians and anyone else that's interested to hear, and also so we can collectively prepare for the weeks ahead. I'm going to start by presenting this COVID-19 tracker. There are many trackers out there. This is one that's actually from Johns Hopkins University, and this compiles cases that are coming from CDC, WHO, and several other organizations. This tracker is actually updated every half hour. You can see the web address at the bottom of the screen. Again, it's just one example, but this is very interactive. It not only helps to track the cases of total confirmed, but also is tracking total deaths and total recovered. You can even zoom in on the country. I regularly zoom in on the US to see what states are affected and what the numbers look like. I think it's helpful from a clinician standpoint, not only in asking our patients about travel history, so you stay updated and know what the hot areas are, but also know what's in your community. And that way we know what we can do to protect our families and community. You have to keep in mind the total number of confirmed cases will vary depending on testing availability. And also some countries are no longer reporting new cases. So just keep that in mind as we're looking at these numbers. As far as transmission goes, I think it's important to know the basics before we move on forward. We know that person-to-person transmission is through respiratory droplets. Those droplets do not travel more than 6 feet and don't linger in the air. Mucous membrane transmission could be directly from coughing, sneezing, talking, or indirectly from touching an infected surface and then touching the eyes, nose, or mouth. And we do have evidence that the virus can persist on certain surfaces for even several days. So again, even more reason for hand hygiene. There have been case reports of asymptomatic carriers as well, so something to keep in mind. As far as prevention goes, unfortunately, we do not yet have a vaccine. So prevention will be based on basically avoiding close contact with sick individuals. We've all heard social distancing, flattening the curve, and all of that. So that's really the most important part of this. Covering your cough, of course, you know to wash your hands for at least 30 seconds. That is far more effective than the hand sanitizer technique, but hand sanitizer can be used if you don't have access to wash hands, and just plain avoid touching the face. Risk factors for severe illness. We do know that the elderly are most likely to progress to severe illness, and also patients with pre-existing heart disease, CHF, CAD, and also pre-existing lung disease. Several examples there. Something to note, we've had a lot of mortality analysis showing that patients will actually develop upper respiratory tract infections and then progress to fulminant respiratory failure. And they actually recover from the respiratory failure, but then ultimately develop what looks like a viral cardiomyopathy and progress to a cardiac arrest. And so something to keep in mind. This slide shows signs and symptoms, and the graph at the top compares COVID-19 signs and symptoms to influenza A, which we're all more used to seeing and treating. Take-home point here is temperature, as you can see, is by far and away the most commonly seen finding in COVID-19, but something to be aware of. 44% of patients in a study that was published in New England Journal of Medicine, only 44% of the patients had fever on admission, but 89% of them developed fever later in the hospitalization. So the thing to remember there is just because the patient is presenting afebrile does not rule out COVID-19. They can certainly develop it later in their hospital course. And you can see the spectrum of other signs that are prevalent there. New evidence, by the way, is showing that some anorexia, diarrhea, and nonspecific GI complaints could be preceding the onset of the URI symptoms. And I wrote there at the bottom, the incubation period to keep in mind is 2 to 14 days. That means from the time that someone is exposed to the virus until the time that they actually manifest symptoms could be 2 to 14 days later. And that's the reason behind the 14-day quarantine period. So even if the person is asymptomatic, they're still quarantined for the full 14 days. Median, of course, is 5 to 6 days, so usually that's the case. So some commonly found lab and radiographic findings. Lymphopenia is by far the most commonly seen lab finding. And you can see there elevated ALT and AST occurs, sometimes thrombocytopenia, but leukopenia and leukocytosis is not as commonly seen. Of note, you may a lot of times see a normal procalcitonin. So I've seen a lot of facilities adding procalcitonin onto order sets for this, only because it may direct the clinician more towards COVID-19 if it's normal. And then I put a comparison of chest X-ray and chest CT on the right side there. And what the take-home point would be is, number one, you can see on the chest X-ray, the chest X-ray is actually normal 41.9% of the time. So just again, because the chest X-ray is normal, does not exclude COVID-19. Most commonly seen findings on both chest X-ray and chest CT would be ground glass opacities and either local or bilateral patchy shadowing. Interstitial abnormalities is less commonly seen. So this screening tool I put together because there has been so many changes coming from CDC in the last couple of weeks regarding screening. Initially, we were told as hospitalists to look at travel history and then risk factors and all these different things. We're at the point now where community transmission is in so many areas that really we should be starting with that first rectangle, which says if there is suspicion of COVID-19, meaning that they have any symptoms that I discussed or any suspicion that they're coming from a high endemic area or anything, you go to that next rectangle, which is place a mask on the patient. And then the next one was place a mask on yourself or any provider that's going into that room. Those rectangles are probably the most important piece to take from this, because this is how we can prevent further clinicians from getting quarantined and getting affected by COVID-19. We really need to be diligent about this screening. No longer is it important about if they've traveled or not. That does not exclude COVID-19. So we really need to be masking everyone immediately upon suspicion and being sure we're ultra careful about that. And on the right, this is actually a new change. CDC just in the past couple of days changed their isolation recommendations. So they're now saying to place patients into contact and standard precautions with eye protection and reserve airborne precautions for the aerosol generating procedures. Previously, they said to put everyone on airborne precautions. Now they're saying only for the aerosol generating procedures. So what is that? That means if the patient's getting a tracheal intubation, if it's manual ventilation, so they're getting bagged, non-invasive ventilation, so CPAP or BiPAP, or any invasive procedures such as endoscopy or bronchoscopy. We've also had evidence that high flow oxygen can be aerosol generating, and even nebulizer treatments. So if you have a patient you're suspecting with COVID-19 and you can get away with inhaler treatments instead of nebs, go ahead with the inhaler treatments. Also, move the patient to a negative pressure room if possible. If you have it at your facility, go ahead and use it if you're suspecting it's COVID-19. If you don't have any negative pressure rooms available, just a private room with its own restroom, closed door is the next best thing. Depending on your facility, you'll have different protocols, but make sure your infection prevention or infection control is notified, and make sure they are notifying your local and state health departments. There are links from CDC's website to make sure you're contacting the right place, but hopefully your facility has something in place for this. And lastly, communicate the need for isolation to family members and visitors of patients. We've had this at multiple facilities where the physician did everything according to this, screening tool, and then we realized afterwards there were family members and visitors going in and out of the room. So everyone needs to be notified about this and why it's happening. This figure was taken from a JAMA article that was actually just published last week, and in regards to critically ill patients. And the main take-home points that I want to point out here: patients with severe COVID-19 are developing an ARDS-like syndrome, and therefore we're having recommendations of conservative intravenous fluid strategies. So unless the patient looks severely volume depleted, they should have a conservative IV fluid strategy. And more of a propensity to go towards pressors in this setting. Also, of course, empiric early antibiotics if there's a bacterial pneumonia. Consider early invasive ventilation rather than non-invasive. Of course, go to lung protective ventilation strategies. There's been case reports of prone positioning to maximize oxygenation during mechanical ventilation, and consider ECMO. And then modifications to the usual critical care. Some of this is basic things, but it's so important in a crisis situation to have it laid out so we make sure we're not missing anything. So admit these patients to a private room, use a face mask, maintain distance, caution when using high flow nasal oxygen or non-invasive ventilation. Again, we should be going towards early invasive ventilation. And anyone intubating or doing any of these procedures should definitely have an N95 respirator and eye protection. And again, be involved in all the planning, be active in the planning of what's happening within your units, be aware of what's going on there. We've had a lot of questions about quarantine, and there's so many different nuances, different situations. This table was taken directly from CDC's website, and it was just updated. This, is taken verbatim, so I won't go through it in so much detail. But the main things I want to point out is how it's organized, so that you as a clinician or anyone that wants to go back and look at this knows what it says. So the epidemiologic risk factor is the first column. So if I'm the healthcare physician that's seeing this patient and I have no PPE, the patient who is wearing a face mask, that scenario would be a medium exposure scenario. So most facilities are recommending that that physician get excluded from work for 14 days. And you can see all the way down the line. So if the healthcare physician is wearing PPE but just not wearing eye protection, that would be considered a low exposure, and they do not need to be restricted from work. But any of these situations of any exposure whatsoever should mean that the clinician is doing BID temperature checks, monitoring for symptoms, and seeking medical attention if any symptoms or temperature develop. I will say that there are some facilities too that are allowing clinicians to come back to work if medium risk exposure occurs, and they're asking them to come back with just a mask. This is the second part of that table, and at the bottom there you can see the web address to get this, this risk assessment tool from CDC's website. This table will go through with patients who are not wearing face masks and what type of risk that entails and what to do about that. This is what the PPE looks like. So personal protective equipment, again, this is taken from CDC's website. It's a visual that we've all now seen. Again, the N95 mask that this individual is wearing is now only recommended for aerosol generating procedures, and that's per CDC recommendations. In addition to knowing when to use PPE, I think it's so important for us to know how to properly put it on and take it off. This is not something that should be taken for granted because this may be where some of the transmission is occurring. So this is also taken from CDC's website. If you don't have it readily available in your facility, I recommend just downloading it and printing it and making it widely available so everyone knows how to properly don and doff the PPE. As far as treatment goes, unfortunately, we don't have any specific treatment for COVID-19 at this time. We do have some antiviral treatments. Remdesivir is one. Favipiravir is a new one that just had, in the last couple of days, was released as a possibility. Neither of these have been approved for use. They are being used, however, at some facilities with some promising results. Favipiravir is the newest one. That was a case of 340 patients that they tried it on in an area in China. They had patients that were tested positive and then had negative results 4 days later compared to patients that were not on favipiravir, and they took 11 days to turn negative. So there are some promising results there. Previously, there was lopinavir and ritonavir, which is Kaletra, an HIV medication. That had some promising results in vitro, but clinical trials have shown that that's not an effective treatment. So that's now being taken out of the treatment protocols. Again, neither of these are being used or have been approved for use. You may have heard of chloroquine and hydroxychloroquine. They have both in vitro activity against the SARS coronavirus 2, the virus itself. But for both of these, clinical trials are underway. I've heard reports of certain countries that are already recommending it. That is not currently recommended in the US. And we really need to be reserving the stock of those medications for patients who truly need it if it does end up being an effective treatment. And lastly, antibacterials, if bacterial infection is also present, should also be considered. There is evidence to show corticosteroids should not be used unless otherwise indicated. So I added some other considerations just in the past few days. I'm sure a lot of you have heard NSAIDs that have gotten a bad rap in this case. So there have been a few case reports of young patients using NSAIDs early in an infectious course, and they experience severe disease. So far, it appears that these cases are anecdotal, and the EMA and WHO do not recommend NSAIDs be avoided when clinically indicated. So it's just too early to tell if that's something to be concerned about, but that's where the concern came from, and there's not widespread guidelines avoiding them currently. Related to ACEs and ARBs, same type of thing. There's been speculation these agents relate to adverse outcomes, and there's multiple reasons for that. But so far, multiple guideline panels have recommended ACEs and ARBs be continued when clinically indicated. So far, the evidence that was against them was on a theoretical basis because of the ACE2 upregulation that occurs, and that's felt to be the mechanism of entry into the body from the virus into the body. But again, so far the guidelines show that there should not be any discontinuation of therapy. And related to pregnancy and COVID-19, we have had no documented cases of vertical transmission. I wanted to make note that there are some neonatal cases of infection that have been documented, but again, vertical transmission has not been verified in any of these specific cases. Prevention, evaluation, diagnosis, and treatment approaches should be similar to non-pregnant individuals. And currently, it's unknown if the virus can be transmitted through breast milk. So really, we should be taking precautions to prevent transmission during breastfeeding or bottle feeding. And again, just knowing the mucous membrane transmission and how that may occur. So I put this slide in here about keeping our families safe. A lot of us clinicians that are going out and seeing patients are concerned about not only our own protection, but also making sure that we keep our families and communities safe. So CDC put this document together, and it's really something that we should all be thinking about, knowing the signs and symptoms, staying home when you're sick, knowing what type of involvement there is in the community, and just social distancing. That's really the best way that we can prevent this from spreading further. Know what's available as far as resources go. Make sure everyone is hand washing, typical preventative types of things, and create a household plan. So consider a 2-week supply of prescriptions. It's really hard for you to take care of your patients when you're unsure about what's happening with your family. So make sure you have everything squared away at home, have plans in place, make sure family's okay, and then do all these preventative things when you get home to make sure we're not spreading it to our families. So one thing we should all be considering as hospitalists is in the event we require emergent coverage planning. It is very possible that our volumes will increase significantly as this continues to play its course. In addition, we may end up having more and more clinicians that are quarantined and unable to work. So two reasons why we really need to be developing a surge plan, and we recommend doing it for the next 90 days. We don't know how this is going to go, so it's just better to be planning ahead. I encourage you to also engage your GNU resident and fellow teams, see how they could be helping, and that could be from the teaching, attending, seeing patients, or changing around the caps, changing around the workflow. Some suggestions here, including a Jeopardy system. So get a voluntary sign up for your clinicians on call. Consider expanding your team. Go out into the community and see who's available and who'd be willing to join your team temporarily. It's very possible with elective surgeries being canceled and outpatient offices slowly closing that specialists will even have the bandwidth to work temporarily as hospitalists. These are uncertain times, so it's always better to have a plan in place so we can have a good way to figure out once the volume starts coming in. Consider flexing shifts too. Flex up in hours, so change an 8-hour shift to a 10-hour shift, change a 10-hour shift to a 12-hour shift, whatever is needed temporarily to cover the patients that need our help. And combine coverage models. So consider reaching out to neighboring hospitals and seeing how you can potentially combine resources. Consider the nocturnist capabilities. Is the nocturnist able to change their hours somewhat to allow for cross cover to be handled otherwise, and potentially them rounding after their night shift or whatever they're able to do, even if they're doing a partial night shift and kind of swing over to do a day shift. And alternate staffing responsibilities, whether it's admitting, rounding, doing a round and go model, reallocating the resources where they're needed the most. So you can have a swing shift that now is being flexed to a rounding plus admissions, and consider remote coverage of the night cross cover just to offload the burden. Sometimes the admissions could be coming in quite too quickly to be handling the cross cover pager as well. So consider even telemedicine. You may have heard that some of the rules and laws regarding telemedicine have changed recently as a result of COVID-19, and so that's something to consider at the facility too. And lastly, have a designated physician. Consider limiting the number of clinicians that are exposed to COVID-19. If your facility has 4 patients that are positive for COVID-19, or even persons under investigation, it doesn't make much sense to have 4 different clinicians going into those rooms. Consider limiting the number of clinicians that can be exposed, if at all possible. And operational considerations. As hospitalists, we impact every department in this hospital, so it's so important for us to be involved and be an active voice, not just to share our input, but also to convey our input back to our hospitalist teams. So I encourage you to be involved in the COVID-19 meetings that are happening at your facility. They're definitely happening, so they would only value from your input. And verify that a screening process is in place. Normally, we would think as a hospitalist, this is something that we're not normally used to. This is something that either administrators or ED puts together, but this is not a time for us to be waiting for other departments to take the lead. If that's not already in place at your facility, I encourage you to get out there and make sure that there's one in place. It will protect you and your community and your patients and everyone. And identify that if there are isolation rooms and floor policies. So if you're the hospital admitting a patient that you feel likely is a positive COVID patient or a high suspicion, make sure that you're admitting to the right floor. And if your hospital doesn't already have a policy of where those patients should go, encourage them to do so. Some of our hospitals have already said, we're going to make 2 East the isolation floor or whatever they've decided. And that way we make sure to allocate all the resources there. All of the nurses, the techs, everyone is aware that those are the patients that are going to go to that unit, and it makes it a lot safer process. Inventory of vents and PPE. As a physician or an APC, you may not be the one taking inventory, but be sure that that's happening. Don't wait until PPE is on low supply and all of a sudden everyone's noticed. Make sure that someone is checking that. An assessment of current testing availability. We know that there's been a big testing shortage. and it may vary depending on what part of the country you're in. So know what's available for not only your patients, but also your clinicians. If any of the clinicians need a test emergently or develop symptoms, know what the process is to get them tested. It may be that they need to go to their primary care physician or an ED, but don't wait until they need something emergently to figure out how to get it. And lastly, consider a proper handoff to your colleagues. The last thing we want as hospitalists is to come into a new list and not know who may be a positive COVID patient. This is the time to solidify those handoffs more than ever. So we want to make sure, however you're handing off to your colleagues, that you identify properly who the PUIs are, persons under investigation, and who the positive COVID patients are. And with that, I'm going to take the time to take some questions. I have asked Dr. Jody Crane, who's our Chief Medical Officer of TeamHealth, to join me in fielding questions, as well as Dr. Rohit Uppal, who is the Chief Clinical Officer of Hospital Medicine with TeamHealth. And the three of us will be taking questions.
Thank you very much, Dr. Sahoo, for that very informative presentation and for taking the time again to share your knowledge and expertise with the field today. We've had a bunch of questions come in through the question box, and so we'll try to get to as many of them as we possibly can in the time that we have remaining. I also just wanted to let folks know that we are recording this webinar, and it will be available as soon as we're able to get it posted after the slide, and we'll be emailing all attendees and registrants with a link to that as soon as that becomes available. So thank you again, Dr. Sahoo, and I'll start with the first question about discharging a patient. So if a hospitalized patient has COVID-19 but is medically stable to go home, however, is deemed to require home care services, is it safe from a public health perspective to send this patient home with home care?
Yes, this is Ruby Sahoo. So I'll take that question and I'll open it up to Dr. Crane and Dr. Uppal. The CDC actually has guidelines on their website as well for this exact scenario, specifically addressing making sure that the patient does not transmit that to others, but also with home care instructions to make sure that everyone else is using proper PPE and still getting the patient the care that they require when they get back home. Dr. Crane or Dr. Uppal, did you have anything to add there?
So Jody, before you go, I'll just say that as part of the preparation, one of the things that we've already started to see is that as we become overloaded with patients, we're also struggling to have the ability to discharge them home with the proper resources. So as part of the preparation, making sure that you're having conversations with your home health providers as well as your post-acute facilities regarding what the CDC recommendations are. We're finding that, in many circumstances, those facilities are being more conservative than the guidelines, which puts us in a very difficult situation where we're not able to get people out the back door and they're still coming in the front door. Jody, any other thoughts?
Nope, no other thoughts. I think you guys covered it.
As a follow-up question on discharge, do you recommend when discharging a patient with COVID-19 for instructions, do you recommend a symptom-based strategy for the duration of isolation or a test-based strategy for isolation?
I can take that one, Ruby.
Sure. Yeah.
So the CDC recently came out with these two strategies, and essentially it actually boils down to one strategy, which is if you've been afebrile for 3 days or 72 hours and your symptoms are improving, that's one piece of it. And then it's if you've had a 2 negative tests 24 hours apart, or you've sustained a duration of 7 days after the onset of your symptoms. And I think the reality here is that most people are going to be using the no test strategy because I think it's really, really hard for us to get tests even in the inpatient setting with relatively sick patients. So we've had a lot of access to testing type of problems. So me personally, I'd be in favor of the no testing pathway. And again, the only difference is you're still looking at 3 days of no fever. You're still looking at improvement of symptoms, not symptoms necessarily going away. But then it's a 7-day waiting period since the onset of symptoms, not since symptoms are gone, and or 2 negative tests. Now, the one thing I would point out is that in order to go back to work as a clinician, you have to wear a mask until all of your symptoms are gone. But I would also say that probably extrapolates into the general working population, probably at home as well. You should probably wear a mask until all your symptoms are gone. We have seen cases where people have come up with another positive test after being discharged. There was that Sentinel case in San Antonio where the patient had 2 negative tests 24 hours apart, went home, and then had another positive test. I think the verdict's out on that, whether these tests are picking up, viral particles that are still in the respiratory tract, or whether these patients truly are getting reinfected. They're probably not getting, if they are getting reinfected, they're probably not getting reinfected with the same strain that infected them the first time. It's either a mutant, but I think that's much less likely.
Great, thank you. We've had a bunch of questions about the change of guidelines for PPE. Some folks asking, for your opinion about why those guidelines were changed. So if any of you feel comfortable providing an opinion on that. But then I think some specific questions around what are actually considered aerosol generating procedures. So are things like DONED treatment or albuterol treatment or pulmonary toileting, would those be considered aerosol generating?
Hey, Ruby, I can also take this because I was looking over all these questions in the chat box while you were talking. Is that okay?
Absolutely, sure.
Yeah, this is one of the most common questions we're getting, and I think it goes all the way back to the early days of COVID, when the CDC initially went on site to a bunch of places. So we had the second case, United States. The CDC was there for 10 days, and they told us, everybody needs to use N95 because we didn't know whether it was aerosol or not. And that opinion has really persisted since that time, even though we know traditionally all the other coronaviruses are droplet spread. So I think all the experts agree that they're droplet spread now. And the implications for that are pretty clear. So to protect yourself from the virus, the best way to do that, as Ruby said, is any patient with respiratory symptoms should have a mask, and you should have a minimum of a mask. A mask with eye protection is a big bonus because you never know whether the patient's going to rip off their mask and cough on you. So if they rip off their mask and cough on you and your eyes are protected and your face is protected with a mask, you're covered still. That's still a low-risk encounter. Now, as far as aerosol-generating procedures, that's CPAP, BiPAP, that's the active intubating. But once a patient's intubated, it's a closed system. So, but keep in mind, if you walk out of the room of a patient that you just intubated and you have your PPE on, and then you walk out and you walk back in because you forgot your pen, those aerosolized viruses will stay present in aerosolized form for up to 3 hours. So just remember that piece of it. And then the last thing I'll say about sort of aerosol versus non-aerosol and N95 versus regular face mask is that there's been this kind of guidance out there relative to quarantine, and Ruby framed it up pretty well in that there's this masked and unmasked differentiation in the CDC, and again, one point that I would kind of really point out on that slide is if the patient is not wearing a mask and you're wearing a mask and a face shield, that's actually a low-risk encounter. But if the patient's wearing a mask and you're wearing a mask, if the patient's If the patient's wearing a mask and you're wearing a mask, but you don't have eye shield, that's also a low-risk encounter. Now, the problem that we're seeing is we're getting providers sent home. So we in TeamHealth, we have 100 providers in quarantine, and we're reviewing all of them. And the problem is we're getting providers sent home that are based literally on those CDC criteria. Now, the reality is the CDC has also come out and said, if you have a critical staffing shortage, that if quarantining your providers results in a fundamental impairment to your ability to provide care, then those providers can come back to work as long as they're not symptomatic, but they need to wear a mask. So New York State has come out with that. That's the policy out in Washington right now. So what we're advising, and we've got a multi-group statement that's going to come out that basically says, even if you have direct exposure, no mask, to somebody who tests positive for COVID-19, you can continue to come to work until you're symptomatic, but you have to wear a mask and you have to use good hand hygiene. That will be the standard of care. I would argue that it already is now. So Rohit and Ruby, anything to add?
Nothing from me. That was perfect.
Yeah, I think you covered it really well. The only thing I wanted to mention there too was the aerosolization. I think one of the questions was specifically about using Duanebs or using different inhaler treatments. I mean, if the patient can use an inhaler, I think that's the way to go rather than using a nebulizer.
Great point, Ruby. And one more follow-on, because I remember this question in the chat too. There was a question about what about CPAP and BiPAP when you've run out of ventilators? And actually, they're doing that in Italy now. What they're doing is they're converting step-down units into kind of non-invasive ventilation units. But keep in mind that whole unit will now have aerosolized. It'll have kind of aerosolized COVID in it. So if you're working in that environment, you'll have to have a full PAPR or CAPR on, where unless obviously you've got an active infection. So if you're already positive but asymptomatic, it's probably okay to work in that setting. But the reality is those patients, that you can do that as a last-ditch effort, but the current recommendations are to go is when you see somebody in respiratory distress, go straight to invasive ventilation.
Great, thank you for that really comprehensive answer and hitting on a lot of the questions in the chat box. We had a number of questions about sort of changing practice in, and managing practices and managing patients in the hospital. And so I think the first question is just, can you talk about how we think about who hospitalists are admitting and discharges, who maybe under normal circumstances would stay, but under an emergency could likely be discharged? So, how can hospital medicine teams sort of rethink the way they might have managed patients who are maybe lower acuity in these times of crisis?
Sure. So I'll give my thoughts there, and I'll hand it off to Rohit and Jody. I've seen some facilities coming up with protocols. Some of them had already had them in place, but now it's just becoming more rigorously adhered to. Things like observation protocols or zip order sets to expedite getting the patient what they need and getting everything done in a more expedited fashion. So if it's a chest pain rule out or TIA, getting everything lined up so nicely so that way they get in and out and get what they need. The other part of that is the social admissions, or if there's admissions that are potentially low acuity, could they be seen by case management in the ED and then potentially discharged home, and the hospital never gets involved. So there's more of an emphasis on some of the social type situations to get them the resources that they need and potentially keep them out of the hospital so they're also not exposed to the other patients. Jody or Rohit, did you have anything to add?
Ruby, I think you covered that very well. And one thing I would add is patients are already doing some of this work for us. We're seeing globally that ER volumes are down. So I think a lot of those, what you might consider discretionary ER visits and or admissions are already being reduced. But you're spot on in terms of looking at your observation cases. Most of the hospitals we're partnering with are considering changing the threshold for admission. So many of those observation cases can be managed as an outpatient. And I think anytime we admit a patient to the hospital, there's a risk benefit analysis that we do. And we're basically saying putting you in the hospital offers some benefit that is greater than the risk. And what has changed now is that risk has increased, especially in scenarios where our clinicians are overloaded taking care of COVID patients. I think that patient safety concerns and other risks, including infection with COVID, just change that threshold. Jody, anything to add?
Yeah, the only thing I would add, I think you guys covered that kind of discretionary population pretty well. The only thing I would add about COVID is, like severe disease as defined by O2 sat less than 93% or 90%, depending on what source you read, tachypnea greater than 30, and PaO2 over FiO2 of less than 300 millimeters mercury. Like, I would say kind of they're pretty straightforward kind of severe disease recommendations in terms of those patients who ultimately go on to have pretty rocky course. The one thing I would caution you about, and what we're doing in the emergency department is and we're treating them essentially, and don't quote me on this, but similar to how we're screening flu patients. Like if you're not sick, you're going home and you're self-isolating. The problem, I think the issue with that potential pathway is what we're seeing is this grace period. So Ruby put up there that slide that had the incubation period from 2 to 12, but also the mean was, or the median was somewhere between 5 or 6 days. The problem with the course of this disease, when you get the flu and it hits on day 1 and you feel crummy for the next week to 2 weeks. Turns out in COVID, you get COVID and you feel great for about 5 or 6 days. And then if you start doing poorly, you tend to kind of fall off the cliff pretty rapidly. So you're in the intensive care unit by day 8, but you don't even really start feeling bad until day 5 or 6. So my point is, I got 2 points for that one. One is, if you send somebody home, make sure that their instructions are clear, and ideally you get somebody to check in on them or get them to follow up with a televideo meeting or something like that. And then the second point that we're seeing out of both China and Italy is when the patients are admitted and they look pretty sick, they're actually deteriorating really rapidly, like admission to intubation times of less than 24 hours. So I would kind of err on the side of caution. If you see somebody, like, they don't look so well, your spidey sense should go off and say, hey, I either need to follow that person quickly, or if I'm overrun with lots of sick patients, you might want to err on the side of intubation.
Can one of you talk a little bit about the use of telemedicine and maybe talk about some strategies on how telemedicine could be helpful in managing patients both with COVID and other patients in the hospital, and then some comments about reimbursement for telemedicine?
Sure. So I'll start that out and welcome any other input. Especially on the hospital medicine side, we've been looking at different strategies, especially now that the telemedicine rules have been laxed a bit in this COVID-19 setting. So thinking about ways that we can use telemedicine to either offload the burden of, for example, cross-cover pagers overnight. How do we help the night team if the admissions start increasing more than they typically would, and things like that. Or even providing telemedicine to provide resources in areas where we're just, with really low staff. So there may be some facilities where there's 1 or 2 physicians working, and if one of them gets quarantined, then we need some emergent help. So that's another possibility where telemedicine could be used. And even just phone consults in general, triaging and things like that. We've also talked about if we get to a point where we have physicians or APCs that are quarantined, but are still able and willing to work and help, can they be the ones manning the telemedicine and still potentially seeing patients, but obviously not in a physical capacity where they're being exposed to anyone? Rohit or Jody, did you want to add anything there?
So I'll just add a little bit. What CMS announced was a relaxation of some of the HIPAA regulations around telemedicine, which is helpful if you don't have a platform. They even, I think, mentioned using FaceTime as an option. So that just gives that availability to facilities or physician groups that are not set up for that. At TeamHealth, we're going to be utilizing Zoom, which is a HIPAA compliant platform. I think the difference between what we'll see during this outbreak versus the telehospitalist programs we traditionally see is we will not be utilizing peripherals just because of the logistics of getting all of that set up in an urgent type of crisis. And so this really will be just kind of video conferencing with patients. And I think you can use that to do daily visits. Potentially even admissions if you're in really dire circumstances. The other aspect of telemedicine I would mention is all of the hospitals and payers that we're partnering with are all urging patients to use telemedicine as their primary vehicle for primary care or urgent care type of issues, including if they're concerned that they have acquired COVID. And so that's hopefully offloading some of our emergency departments and testing centers. Jody, anything to add?
No, the only thing I would add is that I think we're going to have to use some element of telehealth in all of this, but I don't think it's been ironed out how we get reimbursed. And so, for example, if we two big things that people are considering out there is literally on-site telemedicine. And, the idea is you've got this barrier between you and the patient, and it's like you're in front of the patient, but they've got a screen, you've got a screen, and you're just screening them for COVID, so you're not blowing through PPE. Now, CMS traditionally has not covered for on-site telehealth, and we're unsure whether they're going to pay for that or not. The other piece of it is we're really not sure how or if they're going to pay for any of the other telehealth. And then there's the CMS piece of it, but then there's also what are the rest of the commercial payers going to do? They're already really stomping us into the ground on the reimbursement front. What we're worried about is that they won't pay for any of it, especially since they all have their own internal telehealth platform.
Great. We have a number of staffing questions. So the first staffing question is around, for those institutions that have a closed COVID unit, what's your best guess, best recommendation on the census that a typical rounder could handle? And that includes both direct patient contact and telehealth contact with the patient.
This is Ruby. I would say that would vary depending on the acuity of the illness of the patients being seen. I mean, if we're talking about COVID-19 patients and pulmonary respiratory failure on a vent, that patient will require a different amount of time and resources of the clinician than a patient coming in as a rule out. So I think, certainly the CMI, the case mix index, and the acuity of the patient would need to factor into that. Telehealth, I think, changes things a bit because it could be, just a quick follow-up. It could be something that could be almost like the equivalent of a cross-cover type pager issue. It really depends on what the encounter looks like and everything. So On the flip side, if the resources aren't set up and the telemedicine encounter may be even more time consuming. So I think that can vary significantly. I think it would be really difficult to nail down an exact number based on all those factors.
Okay, and there was another question about, and specifically, Dr. Sahoo, you mentioned having designated staff to minimize exposure. Could you talk a little bit about how that, what are some ways that could function for nocturnists? And so the questioner had indicated they had a dedicated cohort team during the day for COVID PUIs, but they haven't really been able to change their staffing at night. So any ideas or strategies that you might have would be helpful.
Sure. I have some colleagues, both on night teams and also in the ER, that are doing similar types of things where if patients are coming in with signs that could be concerning for COVID-19, those patients are getting triaged to one single either ED doc or one single nocturnist. Now it's going to be a little different when you have night coverage with only one single physician, for example, handling the admissions overnight. But if you have multiple physicians and APCs, there could potentially be one person that gets those cases that are flagged as a potential COVID positive or a high suspicion. Really, it just comes down to safety and the numbers.
Ruby, I'll just add, I know we addressed this earlier, telemedicine is another option in that scenario. The other thing I would say is with the limitations on PPE, combined with maybe some groups wanting to protect some of their providers from exposure, this is a scenario where if an ER physician has evaluated the patient, admission orders can be written and the patient can be rounded on the next day by the dedicated hospitalist team. The other comment I'll make is that idea of having kind of dedicated providers, we're using that in most of our facilities where we're seeing sporadic cases. But what we found is once that goes beyond the sporadic case phase, it really isn't sustainable because the number of PUIs and confirmed cases just rises at a rate where everyone's going to have to be rounding on those patients. Jody, anything to add?
Nope.
Another question came in about staffing. Do you have policies or strategies for providers who might fall into a vulnerable risk population for COVID-19? Have you enacted any changes in your staffing for those providers?
So, I live in Myrtle Beach, South Carolina, so we do hurricane planning quite a bit, and I think we've gotten quite used to that part of it. It's difficult to modify it to fit with something like COVID-19, but you could think of it in a similar way that if you have some physicians that are going to have more difficulty or have a social situation at home that they'd have difficulty in a hurricane type of situation or in this situation because of COVID-19, those are the strategies that you really need to be thinking about when looking at staffing. So when we're talking about having a pool of physicians that would potentially see the COVID-19 patients, I would think that the higher risk physicians would be lower down on that list. And I think it just comes down to, having the right team dynamic and, everyone doing the right thing for the greater good.
I agree 100%. I think in order for the hospitalist team to come together as a team and take care of patients, they certainly have to care for each other. And you certainly don't want to be exposing your high risk providers if there's a way to avoid that.
Looking at the time, we have a few minutes. Oh, sorry.
Hey, Josh. Oh,
yes.
Would you mind if I just kind of offered up an unsolicited, I didn't see this in the questions anywhere, but kind of a public health perspective on this?
Yes, please, by all means.
So you know, we saw a couple days ago, or maybe it was yesterday, time's flying here, that California, you know, essentially quarantining people to their homes. I think it was just announced, maybe even on this call or right before this call, that New York was going to do the same. And another interesting thing is today was the first day, or yesterday, the first day that China had no new cases in Wuhan. And if you look back on what China did and kind of equated it to, and you mapped it over the United States, I'd like to just give you guys a thought and then maybe let Ruby and Josh close it up. But on January 23rd, Wuhan was locked down. 3 weeks later, on February 18th or so, 17th, they peaked at 58,000 active cases. Okay? When they went on lockdown, they had 771 cases, and that's confirmed cases. So, but over a 3-week period, they peaked. Now, if you kind of map that experience over the United States, so today, right now, we have 16,638 cases. So if we were to lock down the entire United States today, and we kind of looked at what the virus would do over the next 3 weeks, it's essentially doubling every 2 days. The number of cases is doubling. So we would end up with 16 million cases 3 weeks from now. And the problem with that is that roughly 20% of those will need admission. And 20% of 16 million is obviously a pretty big number. That would be, and 5% of those would be about 800,000 would require intensive care. Okay? So, and call it another 3 million would require admission. So we've got a total of 530,000 acute care beds in the United States and about 100,000 ICU beds in the United States. And all of those are mainly focused in metropolitan areas. So this is going to be challenging for us, kind of looking forward to the next several weeks. But the one point I wanted to make is if this truly does follow the same path of doubling every 2 days, if we do nothing for the next 2 days and then the next 2 days and the next 2 days, that 16 million becomes 32 million 2 days later. And then it becomes 64 million 2 days later. And then it becomes 128 million just 2 days later. So the point is, the longer we wait to stop the spread, the more overwhelmed our healthcare system is going to be. And so, you know, Ruby mentioned in her talk about finding alternative sites of care for intensive care units, for figuring out how you're going to best utilize your ventilators. We talked about backup ventilators. We talked about mapping over CPAP and BiPAP over to ventilators. I would strongly encourage everybody on this call to work on that with their hospitals, because the longer we wait, the more significant the impact is going to be to our entire healthcare system. So, Ruby?
Thanks, Jody. Yeah, I appreciate all of the questions, and I appreciate Jody and Rohit joining me for the panel in answering these questions. We had a lot of great feedback. One clarification I wanted to make in the closing, I spoke about NSAIDs, and there's a lot of information that's going out there. There have not been definitive guidelines saying anything to hold, but the WHO, I did want to mention, put out guidelines just to use with caution, and so I wanted to make sure to mention that. Aside from that, I did add my email to the final slide if there are any questions that we were unable to answer, and happy to take that if needed. And I know we plan on doing future webinars to speak about some of these topics in more detail. Josh, I'll hand it over to you.
Great. Thank you, Ruby, so much, and Rohit and Jody for your time and your expertise today. Thank you, everyone who joined us today for the webinar. As is very clear from the discussion, this is an ever-changing topic, and we will be having future webinars on specific topic areas as well as next week we'll be having a webinar with a public health epidemiologist talking about the sort of 10,000 foot look on the COVID-19 epidemic in the United States. So keep an eye out for emails from the Society of Hospital Medicine for future opportunities, both to learn more about what's happening around the country and to hear from your fellow hospitalists on how they're preparing to address the pandemic. So with that, again, this webinar has been recorded and will be available for folks to watch again. We'll be emailing all registrants and participants today with a link to the recording after that gets posted. And we'll look to hopefully see you all next week on one of our future webinars related to the COVID-19 pandemic. So thank you all, good luck, and thank you for everything that you're doing today for patients and for the country. So thank you, have a great weekend.